Professor Vere puts it, my name is Dr. Hussein Bagha. I am a consultant physician and nephrologist working at the MP Shah Hospital. So I'll be talking today about immune checkpoint inhibitor nephrotoxicity. So if you look at the treatment of cancer, it has evolved beyond the conventional chemotherapy, which was basically quite debilitating to the patients, and the outcomes were also not good. It now includes life-changing therapies such as targeted agents and cancer immunotherapies. So these newer treatments have transformed many malignancies from death sentences to now chronic diseases like systemic arterial hypertension and diabetes. So when you look at the tumor microenvironment, it represents a sanctuary for the cancer cells, which actively create conditions that facilitate the survival and evade the immune system. So the malignant cells combat the immune system by changing their phenotypes to avoid detection and destruction by the tumor infiltrating lymphocytes, which basically kill the tumors. The cancer cells modify and downregulate the surface antigens, which are normally detected as foreign by the MHC, by the T cells. They also express ligands that bind inhibitory T cell receptors, which are known as immune checkpoints, that subsequently deactivate cells. So the immune checkpoints are regulatory proteins that exist to strike a balance between activation of the immune system and inhibiting the activation of the immune system so that the body does not attack the autoantigens or self. So the tumor cells use these immune checkpoints to survive. So if you look at immunotherapy, immunotherapy has been there for quite some time, for the past 2 centuries. Actually, one of the first reported events was when Dr. Coley in the late 19th century reported insertion of a dead bacterial cells, which led to the shrinkage of a sarcoma cell. Since then, immunotherapy has been the holy grail in the fight against cancer because you're using your body's own immune system rather than introducing external agents which can be quite toxic. So over the last few years, there's been a great understanding of how to harness the immune system to combat the cancers. If you look at the tumor immunology, the main key cells that are important when it comes to cancer treatment and destruction of the cancer cells are the CD4 and the CD8 cells, which usually initiate distinction between self and non-self antigens. We also have the natural killer cells. Now, the natural killer cells are part of the innate immune system and do not require antigen presentation, where the measure is the compatibility complex, or MHC, for cytotoxic activity. Then we also have the macrophages, which play an important role in phagocytosis and are also part of the antigen-presenting cells as well. So they're part of both the innate and the adaptive immune system. So if you look at the tumor cell basically has the antigens on its surface, and these antigens can bind to the T cell or the natural killer cell via bispecific antibodies, or it can basically bind to the natural killer cell or macrophages, which can initiate tumor lysis or tumor killing via antigen-dependent cell cytotoxicity. We also have growth receptor blockade or death agonists, and then we have the toxins or chemotherapeutic agents or specific radioisotopes that actually come and bind to the tumors and cause killing. The tumor cells have learned how to evade the immune surveillance system. And one way they do that is by loss of the major histocompatibility complex 1, which is expressed by all cells, including the tumor cells. So that way, these antigens are not presented to the T cells. The tumors can also present immune tolerance, can promote an immune tolerant microenvironment, which leads to production of cytokines, which can then subsequently suppress production of the CD4 and CD8 cells, which are part of the adaptive immunity. The tumors can also upregulate the expression of immune checkpoint inhibitors, like the programmed death cell proteins 1 or the programmed death cell protein ligand 1, which can promote peripheral T cell exhaustion or inhibition. So when you look at the T cell activation, the T cell gets activated by several mechanisms, and it requires several signals as well. The first signal is when the T cell receptor binds to the antigen, which is presented to the MHC class 2, which is found on the surface of the antigen-presenting cell. The antigen-presenting cell can either be the B cell, the macrophage, or the dendritic cell. So this is considered to be the signal 1. Now, this does not lead to activation of the T cell. For the T cell to be activated, it requires co-stimulation. And the co-stimulatory signal occurs when the CD28, which is found on the T cell, binds to its ligand, which is a CD80 or CD86 found on the antigen presenting cell. When that happens, there's a downstream signaling, and which subsequently leads to the translocation of the nuclear factor kappa B, which is found in the cytosol, into the nucleus, and subsequent transcription of the various cytokines like interleukin 2, interleukin 6, and tumor necrosis factor alpha. However, now to keep this in check, we also have the inhibitory signals as well, so that there's no overactivation of the T cells. And one of the mechanisms by which the inhibitory signal is activated is when the CTLF4, which is a cytotoxic T lymphocyte antigen 4 found on the surface of the T cell, binds competes for the CD80 or 86 ligand. So when that binds to CTLF4, then subsequently the activation of the T cell is inhibited. We also have the programmed dead cell protein 1 found on T cells. And when that binds to its ligands, PDL1 or PDL2, it also inhibits the activation of the T cells. So this is the way in which now the immune system is also kept in check, and there is no overactivation of the immune system leading to attack on the self antigens. If you look at the tumor lysis and destruction, first we tend to get the lymphocytes being activated within the lymph node. That is stage 1. After the activation and proliferation of the lymphocytes within the lymph node, these lymphocytes or T cells basically go to the tumor microenvironment and cause the destruction of the tumor cells. So the activation, as I said earlier on, occurs when the T cell receptor binds onto the antigen, which is found on the groove of the MHC class 2 antigen of the antigen presenting cell. Then there's a signal 2, which is the binding of CD28 to the CD80 or 86 ligand. And subsequently, this leads to activation of the T cell. And after that, the T cell moves on to the tumor microenvironment and causes lysis or destruction of the tumor cells. However, once when the tumor starts getting destroyed, it actually releases cytokines which basically upregulate the CTLF4 found within the T lymphocytes. And this CTLF4 competes with the CD28 to bind to the CD80, 86 and inhibits the T cell activation within the lymph node. In the tumor microenvironment, there's also upregulation of the PDL1 and PDL2 found on the tumor cells, and these bind to the programmed dead cell protein 1 found on the T cell, and this inhibits the T lymphocytes as well. So this is the way in which the immune system basically evades, this is the way in which the tumor cell evades the immune system. So these proteins were basically discovered by Honjo and Ellison, and Honjo discovered the programmed red cell protein 1, and Ellison discovered the cytotoxic T lymphocyte antigen 4, and they were both awarded the Nobel Prize in Science in 2018. So this is a mechanism in which the tumors basically evade the immune system in summary. So one of them is basically failure to produce the tumor antigens, which are found on the surface, the MHC class 1 antigens. So there's lack of T cell recognition of the tumor. There's also the mutation in the MHC genes needed for the antigen processing as well. So again, the T cells will not recognize the tumor. And the third part is, which is the one that we're going to talk about, is the production of the immunosuppressive proteins, which basically inhibit the T cell activation. If you look at the timeline for the development of immunotherapy, as I mentioned earlier on, the immunotherapy has been talked about and it's been experimented on for the past 2 centuries. It's only now, recently, in the past decade, is now when we started getting the immune checkpoint inhibitors which target specific proteins. Previously, we used to have interleukin 2 and interferon alpha therapies as well, but I'm sure that all of us know that these basically have got quite a bit of side effects as well. So it's only in the last decade that we have now gotten these targeted therapies, or the immune checkpoint inhibitor therapies like ipilimumab, which was approved for metastatic melanoma in 2011. So these are the current immune checkpoint inhibitors. I'm sure that by the time I'm presenting this slide, I'm sure that very many must have come up. I think in the New England Journal of Medicine, which was published yesterday, there was a new molecule that has been used for targeting lung cancer. So we have the drugs that basically target the cytotoxic T lymphocyte antigen 4, that's anti-CTLF4. We have the anti-PD1 inhibitors and the anti-PDL1 inhibitors. So the CTLF4 inhibitors, there's only one drug in that class. It is called ipilimumab. The anti-PD-1 inhibitors, we have three of them. There's nivolumab and pembrolizumab, which are the most commonly used, and then there's semiplimab as well. Anti-PD-L1 inhibitors are the atezolizumab, avelumab, and durvalumab. So if you look at the pharmacokinetics of the immune checkpoint inhibitors, the ICIs are, all of them are human immunoglobulin antibodies. Okay, all of them are IgG1 except nivolumab, which is an IgG4. And these target different proteins, as we talked about. They either target your CTLA4 antigen, or they target your PD1 or PDL1 antigens. They all have similar pharmacokinetic properties. They're all administered intravenously and have a small volume of distribution. The distribution to the interstitial compartment from the vascular compartment occurs primarily by convection, and it is to the peripheral tissues, interstitial compartment, and target tissues. Now, the time to reach the drug steady state varies for each immune checkpoint inhibitor and ranges from 8 to 18 weeks. These drugs are not cleared by either the liver or the kidneys, so you don't need to dose adjust them when you have liver dysfunction or renal dysfunction. And the clearance is mainly by the non-specific proteolytic degradation in the plasma and the peripheral tissues. The drug clearance is time-dependent, except for ipilimumab, and it is linear. So the immune checkpoint inhibitors are catabolized when they bind to the cell surface receptor targets and undergo receptor-mediated endocytosis within the cytoplasm. Another route of immune checkpoint inhibitor clearance is the formation of the anti-drug antibodies, which bind to the drug and facilitate the endocytic degradation of these drugs. So sometimes we tend to get the drugs binding to the neonatal FC receptors, which are found on the antigen-presenting cells, the neutrophils, and endothelial cells. And the FC receptors recycle the drug from the endosome to the cell surface via transcytosis, where it is then released to the vascular space. So this process contributes to the prolonged half-life of these drugs. And this explains why the half-life is quite long. The other important thing to remember when we're administering these drugs is that for patients who have high-grade non-selective proteinuria, like nephrotic syndrome, they may suffer from impaired immune checkpoint inhibitor efficacy, because remember that these are immunoglobulins and they will get lost in the urine because of the proteinuria. So we have to keep that in mind, especially in patients with nephrotic syndrome. So this is just a summary about the pharmacokinetics of the immune checkpoint inhibitors. As I said, that they are administered intravenously. So this is a vascular compartment. So they can bind to the target cells within the vascular compartment, or they move out via convection to the target tissues where they bind to the T cells. The clearance is basically by when they bind to the receptors and that endocytosed and subsequently proteolyzed within the cells, or they bind to the anti-drug antibodies, and which subsequently increases the clearance as well. However, we have the FC receptors, which are found on the antigen-presenting cells, the neutrophils, and the endothelial cells, and these subsequently recycle the drug, increasing the half-life of these drugs. So these are the various immune checkpoint inhibitors and the pharmacokinetics. So if you look, the pembrolizumab is the one that has the longest half-life, and this is why it is associated with slightly more toxicity than any of the other drugs, especially when it is used in combination. So if you look at the immune checkpoint inhibitor target sites, as we had said, that we have the anti-CTLA4 inhibitors. So what this drug does is that it binds to the cytotoxic T lymphocyte antigen 4 receptor. So this does not compete with CD28, meaning that there's no inhibitory signal, and the T cells can be activated and remain active for longer. We also have the PD1 and the PDL1 inhibitors, which basically inhibit the binding of the two proteins and the receptors. So this allows the T cell, which are active, to remain active for much longer in the body. Now, unfortunately, we will have adverse effects, the immune-related adverse effects, because of the fact that you are making the immune system remain active for much longer in the body. So they can basically attack any of the organ systems within the body. So starting from the brain, that's the neurological complications, ophthalmologic complications. We have conjunctivitis, episcleritis, uveitis. The patients can get Guillain-Barré-like syndrome. They can get a neuropathy. The nerves can be attacked. We can also get the spinal cord being attacked, causing a myelopathy as well. It can cause pneumonitis, it can cause colitis as well. The most feared complication, of course, is cardiovascular, where it can cause myocarditis and pericarditis, and it has been shown to have a higher mortality. The kidneys can also be affected. Fortunately, the incidence is a bit lower than the others. So it can cause acute interstitial nephritis or tubular interstitial nephritis. It can lead to an ATN, acute tubular necrosis, nephrotic syndromes like minimal change disease and membranous glomerulonephritis. It can also affect the skin as well and the GI tract. Colitis is the most common immune checkpoint inhibitor associated immune adverse event. So if you look at the mechanisms of the kidney injury, what these drugs do is that one is that, of course, they can increase the formation of autoantibodies, which can basically attack the endothelial cells, especially within the tubules and also within the glomeruli as well. So these autoantibodies that form against the kidneys are associated with acute kidney injury. We also have PDL1, there's a programmed red cell ligand 1 present on the tubular cells. Now, when we give them PDL1 inhibitors, so these can basically inhibit the PDL1, and subsequently the kidney cannot inactivate the T cells via the PDL1. So there's increased activated T cell presence within the kidneys, and this can also affect and damage the tubular cells within the kidney. Another very important thing to remember is that with these drugs, because of the fact that we are inhibiting the PDL1, the T cell recognition drug antigen after PD-1 receptor blockade causes loss of tolerance to the drug, which is associated with acute kidney injury. So what happens is if you're giving other drugs that can cause acute kidney injuries like PPIs, which cause acute interstitial nephritis, their adverse effects will also be precipitated when you use them together with the PD-1 receptor blockers as well. The T cells can also secrete cytokines like your interferon alpha and your CXCL10, which can cause damage to the kidney as well, to the tubular cells and the glomeruli. Now, there are different types of cells called the chimeric antigen receptor T cells, which is another form of an immunotherapy, which I felt was important for me to mention here. So the chimeric antigen T cells are basically T cells which have been harvested from patients, and these are genetically modified so that we can place an antigen binding domain which can recognize the tumor antigen. And this amplifies the response of the T cell and subsequently leads to the killing of the cancer cell. But again, because of this, there's always a collateral damage because there's overactivation of the immune system, and subsequently you can lead to acute kidney injury and electrolyte imbalance because of the production of the various cytokines like interleukin-1, tumor necrosis factor alpha, and interleukin-6. These are the various immune checkpoint inhibitor therapy associated kidney lesions. Most commonly, they tend to lead to, they cause acute interstitial nephritis. Some of them have been shown to cause granulomatous acute interstitial nephritis. We have had incidences of thrombotic microangiopathy, and there are some that also lead to minimal change disease and acute tubular injuries as well. When you combine the two of the immune checkpoint inhibitors like nivolumab and ipilimumab, most of the time, these ones tend to cause acute interstitial nephritis, which is not responsive to steroids, because as I'll allude to later on, that the treatment for this is basically stopping the drug and giving them steroids. So when you combine these two, for those patients who tend to develop acute interstitial nephritis, they do not respond to the treatments. So these are the various commonly reported renal adverse events. So for ipilimumab, you can see that they tend to cause quite a bit of electrolyte imbalances as well, apart from your acute interstitial nephritis, as compared to nivolumab and pembrolizumab. And this has been thought to be because of the hypophysitis that this drug tends to cause. There are some differences between the CTLF4 antagonists and the PD-1 inhibitors. In terms of their mechanistic differences, we talked about it, that they basically limit T cell response earlier in the immune response, and this is within the lymph nodes or the lymphoid tissues, where they inhibit the activation of the T cells. While the PD-1 inhibitors mainly work within the tumor microenvironment. These are the various cancers that both of them work against. Now, the onset of acute interstitial nephritis occurs a bit earlier on when you're using your ipilimumab as compared to your PD-1 inhibitors, nivolumab and pembrolizumab. So your acute interstitial nephritis occurs 6 to 12 weeks after initiation of therapy, with the longest duration being 26 weeks. For the PD-1 inhibitors, acute interstitial nephritis can occur anytime between 3 and 12 months after initiation of therapy. The glomerular findings is podocytopathy and TMA, which has been reported. No cases of podocytopathy have been reported with the PD-1 inhibitors. CTLF4 antagonist ipilimumab tends to cause hyponatremia, while for the PD-1 inhibitors, hyponatremia is quite rare. And when it's given to transplant patients, there have been 2 cases reported, but there was no rejection per se when given as a solo agent when you give ipilimumab. However, if you're giving your PD-1 inhibitors, they have been associated with rejection. So we need to be very careful when you're using these drugs for transplant patients. So if you look at the incidence of acute kidney injury, now this was basically biopsy-proven acute kidney injury in the phase 2 and 3 trials. And the overall incidence, as I said earlier on, was quite low, was 2.2%. But the non-biopsy proven acute kidney injury, the incidence was much higher. It was between 20 and 30%. Now, grade 3 and 4 side effects, which are the very serious side effects, and for the renal outcomes, it was basically patients requiring renal replacement therapy. It was 0.6%. Combination therapy, ipilimumab and nivolumab, had the highest incidence of acute kidney injury, up to 5%. Individually, ipilimumab had the highest, 2%, nivolumab 1.9%, and pembrolizumab, it was 1.4%. If you look at the cases and the fatality rates, the most common immune-related adverse events is colitis, followed by pneumonitis. Nephritis is quite rare, but the fatality is much higher, as I said, with myocarditis, also with the hematologic and the adrenal immune-related adverse events. If you look at each individual drug, ipilimumab, basically, majority of the times, the lesion it causes within the kidney is acute interstitial nephritis. It can cause granulomatous interstitial nephritis and the podocytopathies like membranous nephropathy and minimal change. And it has been shown to cause thrombotic microangiopathy. For nivolumab, again, acute interstitial nephritis is the most common kidney lesion. It can also cause granulomatous interstitial nephritis and membranous nephropathy. It has been shown to cause some types of vasculitides, which is ANCA negative, and then FSGS. Pembrolizumab, again, acute interstitial nephritis is the most common kidney lesion. It can also lead to acute tubular injuries and minimal change disease and immune complex glomerulonephritis. And it can lead to a rapidly progressive glomerulonephritis, the focally crescentic post-immune GNs. This was a study from France where they tend to biopsy everybody. They're a bit more aggressive when it comes to biopsies. And what they found was that with the PD-1 inhibitors, the most common lesion was basically acute tubular necrosis, ATN. About half of the patients actually had ATNs. So this is algorithm for the management of patients with cancer and acute kidney injury in the setting of immune checkpoint inhibitor therapy. So once when we see a patient who is on immune checkpoint inhibitor therapy and has a acute kidney injury with a rise in your creatinine, if it's stage 1, as per the Akin or the KDIGO criteria, we need to follow them for a week. We need to reevaluate them after 1 week. And if the acute kidney injury resolves within the week of continuing the therapy, we can then subsequently continue the therapy, but we need to continue monitoring. If within that 1 week, the creatinine keeps on increasing and the AKI progresses, we need to stop the immune checkpoint inhibitor therapy. And hopefully by that time, the nephrologist will have been consulted. If the patient presents with stage 2 or 3 acute kidney injury, you need to immediately involve the nephrologist, okay? And if we find out that the acute kidney injury is due to a non-ICPI toxicity, immune checkpoint inhibitor toxicity, or for example, urinary tract obstruction or another cause of AKI, then we need to treat that underlying cause of AKI. If there's no other cause and it's potentially due to an immune checkpoint inhibitor related nephrotoxicity, then basically we need to assess and see if there are other clues that will actually guide us to it being an immune checkpoint inhibitor related nephrotoxicity. So if the patient has no other immune related adverse effects, the urine is bland, the tubular cells, I mean, there's no injury to the tubular cells or no granular cast, then subsequently we need to do a kidney biopsy. But if we find that we have other organs being involved, like the patient has some dermatitis or colitis, and the patient has a sterile pyuria with WBC casts pointing towards acute interstitial nephritis, then we need to hold the immune checkpoint inhibitor therapy and treat with steroids. And we need to reassess and see whether the patient recovers. If the patient can recover, then we can restart if the benefit outweighs the risks. If the AKI progresses or the AKI does not recover, then we need to biopsy the patient again. And if it's acute interstitial nephritis, again, we can treat with higher dose of steroids and restart the immune checkpoint inhibitor therapy when the AKI resolves. Again, this is in consultation with the oncologist and the nephrologist. Okay. So in summary, cancer immunotherapy has revolutionized the treatment of malignancies by engaging the patient's own immune system against the tumor. It's a very nice form of therapy and it's very effective, but it comes with its own collateral damage. The ICI therapies cause immune-related adverse events that can affect any organ in the body. And most of it can be benign, but remember that there are some case fatalities, especially if you get myocarditis or pericarditis. Acute kidney injury is a known complication of immune checkpoint inhibitor therapy, with acute interstitial nephritis being the most common lesion. And a renal consult should be sought early and a kidney biopsy performed if there's low risk for the procedure of the kidney biopsy to ascertain what type of a lesion you're dealing with. If it's a high-grade acute kidney injury and if it's a progressive acute kidney injury, the immune checkpoint inhibitor therapy should be stopped after consultation with the oncologist. And a course of steroid therapy may be useful. And if the acute kidney injury resolves, then we may restart the immune checkpoint inhibitor therapy. Thank you very much. I'll end there and take any questions.